Good evening, everyone. On behalf of Society for Study of Pain Pune, I welcome you all for this one more webinar from the society, Pune Pain Society. Till now, we have conducted almost 6 to 7 webinars in this year. And I think this is the last webinar of this year because we all are very much enthusiastic and busy in the preparation of ISSP Con Pune 2024. So I welcome you all. I welcome Lokapur Madam, Nankar Sir, Priyadarshini Madam, and Dr. Sunny. Welcome to the webinar. And we will start. I hand over to Dr. Nivedita to introduce the speaker. So Dr. Nivedita is our own faculty. Just a minute. Can you share the screen, Nivedita?
Yes, ma'am.
Or I'll share. No worries. Yeah, so let me introduce Nivedita. So she is founder director for Penix Pain Management Clinic in Pune. And she's also consultant at Jupiter Hospital, Sahyadri Hospital, Joshi Hospital, and MJM Hospital. She has a keen interest in cancer pain and has developed and published protocol for cancer wound dressing with analgesia, and which is now widely used in palliative care community. She has also several academic and non-academic publications. So welcome Dr. Nivedita, and I hand over to you to carry on the session. Over to you, Nivedita.
Yes.
I'll stop sharing.
Yes. Thank you, madam, for the kind introduction. And I am highly obliged that I am able to moderate this session for a topic that is very close to my heart. And the cherry on the cake is all my mentors and my teachers. I'll be introducing them myself. So without wasting any further time, I will introduce Lokapur ma'am. Frankly speaking, she needs no introduction, but just for formality, she's the founder, president, and trustee for Society for Study of Pain, Pune. She's the president of the Indian Society for Study of Pain for the year 2020-21. Currently, she is a consultant in pain management and palliative care at MJM Hospital, Jehangir Hospital, and Ruby Hall. And she has authored a handbook of pain management and palliative care. She's a faculty for national and international conferences, and she has received several prestigious awards, which may not be in the scope of this introduction. So I welcome Madam. She is the expert panelist for today. I welcome Madam to just say a few words and to set the stage. Over to you, Madam.
Thank you very much, Dr. Varshali and Dr. Nivedita. It's a great feeling to be here in this prestigious panel with Dr. Nankar, Dr. Priyadarshini, Kulkarni, and Sunny, who are working very efficiently in field of not only just pain, but in palliative care. I think today's topic is very, very important for all of us because pain physicians working in different spheres, whether it is as an individual running independent pain clinics, whether working in institutes which will have pain and palliative care departments like what Sunny is doing, or Dr. Priyadarshini Kulkarni, who was associated with SIPLA Palliative Care, which she single-handedly brought up, and it is now a very well-established role model for palliative care in our country. And Priya is also doing independent consulting at various places. So people from all walks of life, they visit either a clinic or an institute, or they consult corporate hospitals. So a pain physician is very, very essential for any type of palliative care. So all the palliative care people should be aware of the role which you can bring in, whether it is regarding interventions in the form of MIPSIs or medicines or whatever that we add the value to it. And corollary is that pain physicians should actively go and join palliative care units because their role is going to be invaluable in these services. So let us hear from all these experts about their experience. Today's program actually is not about lecturing people on how to take care of certain aspects or symptoms, but these are actual experiences by all these stalwarts regarding how they manage cases in their personal practices. Over to you, Nivedita.
Yes, thank you, ma'am. So today's topic is it's going to be a case-based discussion, and mainly through that we are going to know how we can practice palliative care in our own little way in across various setups, and that's how the topics and the speakers have been chosen. So now I would like to introduce. I'm just sharing my screen. So our first speaker for the day is one second. Yes. So our first speaker for the day is Dr. Priyadarshini Kulkarni. She is the in charge for the Elizabeth Kubler-Ross Foundation. She's the lead mentor for the CTC project with AIMS Delhi. Currently, she's a consultant in palliative medicine at Jupiter Hospital, Jehangir Hospital, Joshi Hospital, Ratna Hospital, Sahyadri, Symbiosis, and Ruby Hall Clinic, Pune. So her major achievements include she's written a very beautiful book, Touching Hearts Gently. She's the past medical director at Cipla Palliative Care and Training Center. She was the national secretary of the Indian Academy of Indian Association of Palliative Care from the year 2014 to 2017. She played a major role in the end-of-life care policy with the Indian Society for Critical Care Medicine. She is a board member of Worldwide Hospice Palliative Care Network, and she started the first MUHS-recognized Palliative Medicine Fellowship. So I deeply respect Madam, and she's one of the reasons that I chose this field after I listened to her lecture at BJ Medical College. So always an honor listening to you, ma'am. Over to you.
Thank you, Nivedita. Can I just share my?
Yes, ma'am.
Yeah. So when Dr. Nankar spoke to me and he said, Priyadarshini, we need to have a discussion-based lecture on pain management for pain physicians, I was like wondering, they know everything and what am I going to talk to them? But soon he said that we need to cover the palliative care aspects, and then I was okay, like because pain management is an integral part of palliative care. So today we are going to understand. Nivedita, I am not able to move my top bar upstairs.
Ma'am, you will just need to stop hovering over that bar. If you just take your cursor down, it will go up on its own.
Okay. Okay, so today we will see the basic concept of total pain, familiarize with different components of total pain, then see how to assess and manage total pain, and if possible we also can see how we, by doing this, we can improve quality of life of our patients. So as we all know, goal of pain management is to develop and execute a treatment plan to relieve, reduce or manage pain. And how do we do that? Traditionally, we take history to assess type, intensity, pain, mechanisms we understand, and then if there is a temporal variation, and response to treatment based on finding out about the etiology of their pain, understand the pathophysiology of that pain, and find out impact on patient's functional ability. Of course, we do physical examination, and if need be, we do some investigations. Most of the times, somehow, we forget to do psychosocial and spiritual assessment. So I'm starting with this case study of this little girl, Shraddha, and I have taken permission whenever we have taken photos of these patients, which are in the presentation. She was 12-year-old girl diagnosed with osteosarcoma. She had severe pain. Her pain was continuous. She explained it as a throbbing pain. She was not able to sleep any day. Pain was mainly around the left knee joint. It was more on movement, but she was also describing it as pain being there all over the body. We started her on analgesic. She was on morphine for some time and she was better, but there was never a complete pain relief. So can we just imagine, Nivedita, I'm not able to take it up. Okay.
Your slides are not moving.
Now?
It's on the objective slide still.
So,
Ma'am, should I share? No, but I
wait, I'll just share it again and let's see. If not, then you can. Now?
Yes, ma'am. It's come to gate control theory.
Yeah, okay. So I'm just not able to shift that bar upstairs. Okay. Now it's okay. So as we know from Melzack and Hall, gate control theory, pain is a complex perceptual and affective experience determined by attention, anxiety, past experiences of pain, the meaning of each stimulus that gives rise to pain, the state of mind of a person at the moment of pain, and sensory nerve patterns evoked by that physical stimulation. So in short, the input modulation by emotions and cognitions determine the pain experience of an individual. So what is pain? We all know the different definitions, but pain is basically what patient says it hurts. So in Shraddha's case, though we were talking about why she is not getting complete pain relief, what medication we can add, what co-analgesics we should be giving her in addition to whatever she was getting, her needs were to be able to play with her friends, which was not possible because of her pain, to be able to go to school, which was again difficult. She wanted to take part in dance competition, and also not to be the burden to the family. You can see in this picture, she is slightly smiling. She is better and not looking in pain. What might have changed this from earlier picture to this? Maybe in addition to our physical pain medication regimes, our social workers and counselors, they sat with her. They understood her. They tried to do, you just saw the picture drawn by her. Our volunteers used to regularly sit with her and try to draw some pictures with her on a daily basis so that she feels that she is worth something. Even if she cannot dance, she can draw at least. So going ahead, talking about total pain, we cannot miss talking about Dame Cicely Saunders. She was a social worker, nurse, and a doctor who started first St. Christopher's Hospice in London in 1967. She was the one who coined the concept of total pain in early 60s. She first emphasized on multidimensional nature of pain experience. And she is the one who said that understanding total pain is a prerequisite to adequate pain control. So if we just do pain assessment pertaining to physical pain, our assessment is incomplete. Again, few case stories. This gentleman had a real physical pain because of bone metastasis. He had traveled about 200 kilometers in an ambulance when he reached here. you can have a look at him and you can understand that he is really having severe physical pain, right? Look at this second picture where this old person, when I went for the rounds, told me that tomorrow I am going to go home because it is my grandson's birthday. Next day, when I went to the wards, he was still there. And when I asked, he said, no, I don't want to go because there will be too many relatives who will be coming, and I don't want to be there with the Riles tube hanging in there. This picture was taken when his grandson came to meet him. So, was he in some sort of pain? This lady, again, a very dear patient of ours, and a very good family members, she went back earlier where family learned how to do the dressings. But when this time she came in with maggots. Family was feeling miserable because they thought that they did some problem they were not doing the dressings properly. But this lady was feeling, how can I get maggots in my body? How can I be so ugly? And she was not able to mix with other patients, was not able to talk to other patients, and she was feeling really not nice about herself. Hello? Was she in some type of pain? This young man who was sitting in our wards all the time like this, he was about 35, 36 years old, was a gutka chewer, and his half the face had gone because of his cancer. He was recently married, and soon after that, he was diagnosed with this cancer. His wife left him, and the only caregiver and a breadwinner in the family was his old mother. Mother was very angry with him because the age at which she was expected to be looked after by son, she had to look after him. And whenever we went and asked him, are you okay? Do you need anything? How is your pain? He would say, why is this happening to me? All the time. Otherwise, he was sitting like this all the time. So was he in some type of pain? Of course, yes. Everybody's pain was real, and everybody's pain had a different dimension. And this, when physical, social, psychological, and spiritual components of pain are looked into, I think we then only can reach up to total pain management. So, in short, we have to distinguish between what is pain, that is physical pain, and what is suffering. And we all know the definition of pain, but the definition, when we call somebody suffering, it is the distress associated with events that threaten the intactness or wholeness of a person. Many psychological factors are part of suffering, including their thoughts, emotions, and stress levels. We will explore this ahead, but it is important for us to understand that when we are talking about patient with cancer having pain, it is just not the pain because of illness, because of cancer treatment, or it could be unrelated to cancer treatment, but it could be, person could be just very angry at his delays in the diagnosis, maybe therapeutic failure. He has gone through many cycles of chemo, but he is not achieving the effect what he aims at. It could be helpless feeling, or it could be, as this last gentleman was, like, what is the point of all this? Why has this happened to me? This young man used to ask me, like, all my friends were having gutka, why only this thing happened to me only? Or there could be other pain in terms of worries about finances, future of the family members, loss of income, and their role in social circles, and maybe they are feeling very lonely. So how do we deal with? I'm not going into physical problems and assessment at all due to lack of time. And Nivedita, please give me a time check, right? But we are talking about psychological distress here. If you look at this lady, what is apparent is she looks pale, obviously. She is breathless, tired, on oxygen. But what is not apparent is the fear of death, fear of worsening pain, sense of worthlessness, and concern about the family members. When we only do physical assessment, we are likely to miss the second part totally. For that, we need to have enough time. We need to be willing to listen to their concerns and then work on that. This is our another patient. She was 48-year-old, divorced with 2 children, metastatic breast cancer. She was working throughout, but recently she lost her job. And therefore, though she realized that there was a lump in the breast, she delayed going to the doctor, and therefore there was delay in treatment. She always was an angry person or not very easy person to deal with, according to her. She now thinks that she deserves all the pain and suffering, and she is not a good mother. Because she was working long hours and she couldn't pay attention to her daughters. They were not performing good in the school, and she takes the blame on herself. She declined to take pain medications and thinks that suffering all the time is her only punishment. How do you deal with that? Is there pain which is real? Is she suffering? What's happening here in all these examples is somebody has a physical component which is glaringly coming in front, but somebody has a dominated psychosocial issue, or somebody has a spiritual pain, and it is interconnected for each and every person of that. And when we are talking about chronic pain, all these components add on to more pain. It leads to anxiety, insomnia, hopelessness, and helplessness. And these interactions of these variables lead to understanding of what exactly their pain is, what is the level of pain they are going through. So as we talked about suffering and understanding the person as a whole, I think holistic pain management or total pain management, we have to understand that it is multifaceted symptom where the solution is not simply resolved by medical intervention. It considers this emotional, mental, and spiritual needs of the individual in addition to their personal physical state. And obviously, one person cannot look after all these facets. So we need multidisciplinary team. I think Dr. Sunny will speak about it. So as we do pain assessment, PQRST, we have to see how we can do psychosocial assessment. The simplest thing what you can do is when you go to see a patient, you can ask them, what are your major concerns? What is your understanding of this pain? What does this pain mean to you? And by this, I will tell you the example. We had one young lady having CA breast. Her mother also had a breast cancer and her aunt also had a breast cancer. Both of them, they had passed away soon after they had excruciating pain. Both of them, they were diagnosed pretty late. And when this girl, this lady, had pain because of her breast cancer, she thought it is her time to die. So that's the meaning of that pain for this girl.
Ma'am, we have 5 minutes more.
Okay, thank you. Are there any changes you notice in yourself due to this pain? Do you want to discuss different options to treat pain? You know, sometimes we only imagine that whatever allopathic medication line of treatment we are giving, that's the only one people would want to take. But the reality is they maybe have taken all their life some Ayurvedic treatment. They believe in that. And if we don't give them the chance to talk about it, we will never know about it. I'm not saying we should be endorsing or not, but we should be asking them openly so that they open up to us. Whether the cost of pain medication taken so far is bothering you. All this is a part of assessment. and it requires enough and more time with patients. We need to listen to them and we should be willing to help them. Again, 2, 3 next slides are very important and for us to understand what is existentialism is the philosophy about suffering that comes in relation to freedom to make choices, searching for meaning, understanding the reality of death, feeling of isolation, and the pain of existing as a human being. What is spirituality? I have been talking about spiritual pain, but spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the higher up or the sacred one. It's very difficult, and you have to see patients, be with them to understand each and every word really. So why should we be doing spiritual assessment while we are doing pain management? Because all this is happening in the background, and these needs may increase and intensify with severity of pain. Spiritual care, when we give, it improves or helps to improve quality of life of these patients. If we don't do spiritual assessment or we fail to do that, it can increase the chances of patient getting into depression or being sad and not being fully pain relieved. It helps to facilitate good doctor-patient relationship, and patients can tell us what is right for them. There is a difference between correctness of treatment and appropriateness of treatment according to their condition, and they have a right to decide for themselves. So coming back to this Savita, who I was talking about spiritual pain, she was in pain always. She was feeling guilty and depressed. She was unable to sleep, expecting her husband to forgive her and wish to meet her children one last time. When our team did that, this was the expression she had on her face, and she said, "Thank you for understanding me." We have to go beyond this pain as a symptom and treating it as a human being. So this is a list of questions they may have as a spiritual questions. How do we deal or assess spiritual distress? There is a mnemonic called FICA. We should ask them, do you have spiritual beliefs that help you cope with stress? Do your beliefs influence how you take care of yourself in this illness? Are you part of a religious or a spiritual community? And do you have any concerns that we could help you with? We need not be the expert in spirituality, but we can give them that openness and try to connect them if they have some specific queries to help them heal themselves. We should not be forgetting, look at these pictures. Too often we underestimate the power of touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have a potential to turn a life around. When we are dealing with total pain, there is always this thing that palliative care, there is no hope. It's not totally true. This young girl who came to us was dying. When her pain relief was done with medication, she hoped to live longer for this child. When she realized her pain intensified due to knowing of prognosis, and looking at her, family started becoming helpless. What helped them is to realize she is free of physical pain. She was assured about son's future. And till the end of her life, there was a team to look after her so that she doesn't have to suffer. We all know that pain is a more terrible lord of mankind than even death itself, as said by Albert Schweitzer. And pain changes your life forever, but so does healing from it. I think total pain management is integral part of palliative care, and therefore palliative care is everybody's business. We as a physicians, we can be the primary cause of patients' suffering in their last weeks of life or the primary cause of their relief. Thank you. I stop sharing here.
Thank you, ma'am, for that wonderful talk. So, ma'am has not only explained about the concept of total pain, which we have heard a lot of times, but she has also kind of given us a guideline as to how we can even follow it. And her talk reminded me of a quote from Paul Kalanithi's book, When Breath Becomes Air, that all of us as physicians, we tend to, especially interventional pain physicians, we think of, what block we can give, what we can do. But at the end of the day, we have to remember that at the other end of our needles is an actual patient with actual emotions.
Mm-hmm.
And ma'am has brought that out very well. So questions we will be taking towards the end of the talk. All questions we will take together. We'll move on to the next talk today. So the next speaker for the day, I'm sharing my screen, is Dr. Sunny Mallick. So he is the consultant in charge for the Department of Pain Management, Hospice Care and Palliative Medicine at the Rajiv Gandhi Cancer Institute, Delhi. He is affiliated over there, and he has a lot of achievements. He has the Susan Raj Young Pain Physician of the Year Award, Outstanding Reviewer Society for Healthcare and Research Development, Best Emerging Anesthesiologist of Delhi in 2014, Young Scientist Award in 2014, Excellence in Pain Medicine Award. He's also authored 2 book chapters. And as far as I know him personally, he's extremely dynamic and passionate about the field. So over to you, Dr. Sunny. I will stop sharing my screen.
Thank you. इसको ऊपर ले जाना है तो ये ऊपर
Your screen is visible.
Okay. Yeah. Thank you, Dr. Nankar and Society for the Study of Pain, Pune, for giving me this opportunity. And thank you, Dr. Priyadarshini, ma'am, for the excellent presentation. So, as discussed with sir, I will be speaking about the practical and the clinical aspects of mainly the hospital-based palliative care treatment. So, as the topic which has been given to me, palliative care as a catalyst for the cancer patient's journey. So, as you can see in the picture, if we talk about catalyst, what is a catalyst? What is the definition? Catalyst, it lowers the activation energy of the reaction's transition state by providing an alternative pathway for the reaction. As you can see in the picture, the blue mark, the energy is more and it is an uncatalyzed reaction, and the lower one, the red one, is a catalyzed reaction where the activation energy is much lower as compared to the blue one. So if we correlate it, if we go for the products, so what is the product? The product is the good quality of life of a cancer patient and definitely a good end of life care. If we go for the disease-directed therapy treatment till the last moment, for the critical care and ICUs and transitioning towards palliative care is not done. So if we relate with the blue chart, the activation energy, which is in the form of the disease-directed treatment, it increases the cost of the treatment as well as multiple admissions to the hospital. But if the catalyst is early palliative care, what do you mean by early palliative care? It is palliative care which is to be incorporated at the time of the diagnosis, where 80% part is to be done by the oncology side and 20% part of breaking the bad news and communication is to be done by the palliative care specialist. And secondly, the new term is the timely palliative care, Timely palliative care comes when there is increase in the symptom burden like nausea, pain, vomiting, constipation, diarrhea, breathlessness. These things are getting on the increase with progression of disease, and the patients are now on third or fourth line of chemotherapy or palliative RT. So at these moments, the individual work to be done by the palliative care specialist and the oncologist, it becomes 50-50. So this is known as the timely palliative care, and it is the time where we prepare the patient for a good end of life care. So if this is incorporated early or timely in the disease trajectory of the cancer, so this activation energy as shown in the picture and the red part, that is the multiple admissions or the financial cost, it gets reduced, and the final end product here also is a good quality of life and end of life. So what is a catalyst? It is a substance that speeds up the rate of a chemical reaction. It creates a bond with the reactants. So as a palliative care specialist, you have to create a bond with the patient by building a good rapport as well as with the family members. And the end product is release of products and moving on for another reaction. So what you do by creating this rapport? You are creating awareness, you are giving knowledge and education to the family members in the trajectory of the patient. So now you are creating more members in the society that will create awareness for palliative care in the long run. Now coming to the patient. This patient had diagnosis, he was 76 years old. He was diagnosed with triple malignancy 2 years back. He was having metastatic carcinoma of the lung, carcinoma of thyroid, as well as the prostate. So it was a case of triple malignancy. As far as the comorbidity is concerned, he was hypertensive, diabetic, hypothyroid. He had history of coronary artery disease. He was post-CABG, which was done in 2003. 2014 and 2018, some grafting was done, and the recent angiography scan showed that in these grafts also there was 60 to 70% stent stenosis. So that surgery was done around 2 years back. He had taken multiple lines of chemotherapy and immunotherapy for the lung cancer. He was post-radiation, which was given to the metastasis, that is the bony metastasis. And when he was referred to the palliative care department, he complained of pain. This pain was in the abdomen. It was vague pain with a visual analog score of 5/10, associated with nausea, sometimes vomiting. Generalized weakness was there. Fatigue was a common symptom in this patient, and constipation associated with on and off spurious diarrhea, which was usually occurring over a period or a span of around 15 to 20 days. Symptoms, they are increasing gradually and now abruptly over a few weeks. And yes, as far as the symptomatology is concerned, patient was having troubles in weeks. So there was progressive disease, and it was also shown on the repeated PET scan. This was the PET scan finding. There was an upper lobe mass with irregular consolidation. There were post-URP changes which were done for the CA of the prostate. And there was mid-ascending colon lesion. It was irregular concentric wall thickening. SUV max was 46. That means the metabolic activity was very high. It was associated with a luminal compromise, and it was in close relation to the lateral abdominal wall. Moreover, there were multiple lymph nodes studded in the abdomen. There were also active hypodense lesions in the liver. Recent CT scan was also done from the oncology side, and they also showed the similar findings. Now, in the first line of discussion, we saw the patient as proxy patient. Patient was not there. Two daughters of the patient came for discussion in the palliative care clinic. Symptoms were discussed in detail, and a talk was done with the treating oncologist. Whenever a patient is referred to us, we always have a word with the treating oncologist to know what is the further line of treatment from their side. Attendants were also counseled, and it was told that we had a talk with the treating oncologist too. Now the transitioning is going to take towards the palliative care and much more the hospice care phase, that is last 3 to 6 months of life. So the palliative care role and the need of palliation of symptoms plus the hospice care, it was told to them as per the Indian Council of Medical Research Policy and the Indian Association of Palliative Care documents. One more thing has to be explained in detail to the palliative patients. This is known as the doctrine of double effect and the doctrine of proportionality. बुक्स में लिखा हुआ है कि हर चीज की एक गुड साइड होती है और एक बैड साइड होती है, एंड द मोस्ट कॉमन एग्जांपल व्हिच इज कोटेड इन द बुक्स is for the palliative sedation with midazolam during the end of life care phase. But doctrine of double effect, it plays a role in each and every symptom. For example, in this case, one more finding was there, and it was bleeding. Recently, colonoscopy was done just 15 to 20 days back, and the gastroenterologist tried to cauterize the lesion in the colon, but they were not be able to do so. So there was occult blood in the stool. So doctrine of double effect again plays a role in this case, because as I already told in the comorbid status, the patient was having stent stenosis and he was post cardiac bypass and post graft stenting was done. So patient was on anticoagulants. तो आपको डॉक्ट्रिन ऑफ डबल इफेक्ट यहाँ पर भी समझानी है कि अगर हम ब्लीडिंग को रोकने की मेडिसिन देंगे, सो स्टेंट स्टेनोसिस कैन इंक्रीज एंड द पेशेंट कैन हैव एंजाइना. बट अगर हम एंटीकोगुलेंट देते हैं in regard to the stent stenosis, so this bleeding will go on and the patient will land up into hemorrhagic shock. So this doctrine of double effect, it plays a role at each and every moment of the symptoms. Anticipated events in the form of bleeding, as I already explained, cachexia and loss of appetite because it is a part and parcel of progression of disease. Pleural effusion, it can occur. It can be due to hyperproteinemia. Moreover, when the lung lesion will spread towards the pleural margins, so there will be increase in the fluid in that cavity. Electrolyte imbalances because patient was having liver metastasis and they are nutritionally unstable. So there are two of most common offenders in the electrolytes which we have seen in our practice. One is patients, they have usually hypomagnesemia, and the second most common offender is hyperproteinemia. So it was also told that these things can happen in future. Because of the bleeding, there might be chances of hemodynamic instability with a low blood pressure and an increased heart rate. Hyperproteinemia usually occurs with progression of disease. However, the margin for albumin transfusion in our case is 2.5 or less. And definitely because the PET scan finding was showing an ascending colon, a lesion in the colon having compromise of the lumen. So there are likely chances of this patient going into subacute intercellular obstruction whenever he will have a slight lower level of potassium. Moreover, terminal delirium can set in, so there might be restlessness or agitation. It can also be due to jaundice or hepatic encephalopathy. Stent stenosis leading to angina when we will transfuse either FFP blood products or vitamin K and Tranexa, and these all can lead to risk of death. These were explained in detail to daughters. So what we do in our clinic is we give small amount of information to the family members and we call them for the second round of discussion with the patient, so that they can have time to assimilate that information, to absorb that information. They will have multiple questions. So we usually tell them, you write down these questions on a piece of paper, क्योंकि जब आप हमसे मिलने आओगे तो वो questions आप शायद भूल जाओ. So we answer all these questions and then only we make a plan for the further line of management. Pain is a very common symptom in every cancer patient because still today they are usually diagnosed in the stage 3 and the stage 4 with advanced malignancy, and the prevalence of this pain is more than 50%, but as the disease severity increase, it can go, the data says it can go up to 71%. So we have to prioritize. कि हमें सीवियरिटी ऑफ पेन को ठीक करना है या फिर डिजीज डायरेक्टेड थेरेपी की तरफ जाना है. And at one moment of time, the main focus or the priority is pain relief that comes under the umbrella of palliative care. So, after the second line of discussion, a plan was made that we will titrate the dose of the analgesics. As far as the analgesics are concerned, two analgesics are very important, either the morphine tablets or the fentanyl patch. Need of admission, because we are into hospital-based palliative care, we usually admit the patients. So need of admission was explained. Nerve block in the form of minimally invasive pain and spine interventions. We usually counsel कि हम इसको देंगे, क्या देंगे, that we will decide later on after seeing the patient and seeing the progress of the patient as an IPD patient. Desensitization schedule is also a cocktail of Zylocard, ketamine, clonidine, midazolam. These medicines, sometimes they are also used. And the most important thing is, if the patient wants a quality life, so we will develop a support system for those patients as well as the family members. So the need of follow-up visits is important. It has to be explained. So initially, we usually write the goals of care are mainly pain management and the control of the symptom burden. They came again. Now the wife came and the other two daughters also came with the patient. All the queries, जो भी questions वो लिख के लाए, that queries they were addressed. Why we are doing admission to see the progress and doing the rapid titration of analgesics, it was explained. Communication, it holds a very important place. Usually we say that communication in palliative care should be therapeutic. Your communication in palliative care should work as radiotherapy or chemotherapy. आपको इस level तक उसको लेके जाना है. All the supportive care measures apart from pain management that have to be taken care during these admissions. Advanced directive policy, we usually ask अगर आपको उसके बारे में सुनना है. So it was also explained because these the attendants, they are very learned. Patient was very well educated. So they were explained to the wife and the daughters, and two things were explained. One, the living will regarding the finances, and second, regarding the surrogate decision maker when patient will not be able to take the decision for himself in near future. Again, just before admission, we again sit with the patient's family, and doctrine of double effect is again explained and signed. And all the psychological, spiritual, and emotional burden was addressed, keeping in mind the WHO 1986 guidelines, which said relief of psychosocial and spiritual problems is paramount. Attempting to relieve pain without addressing the patient's non-physical concerns is likely to lead to frustration and failure, and that failure will not only be on the part of the patient or the family, it will be also on the part of the palliative care specialist. So as Dr. Priya ma'am said, we have to see for the total pain scenario. So the first thing which we got was anxiety.
Sunny, we have 5 minutes more.
Okay. The first thing was anxiety regarding the future treatment, and his daughter was abroad in Germany. So whether she will be able to make it. Sufferings, definitely कहना आसान होता है कि मुझे डर नहीं लगता, but definitely everybody feels that pain. He was a cheerful person, so finding out depression in such patients is a difficult task. Past experience regarding the multiple admissions in the 2 years was challenging. He was having anger because उनको घूमने का बहुत शौक था, especially to malls. So he was not able to do it because of the fatigue. Fear of end of life care के क्या होगा. This was very important for him. He wants to go to Dehradun at his native place and wants to meet friends at Shillong. Having pani puri was also very important for that patient, और वो हमने उसका कराया. Finances handling, especially for the care process, जो last moments में होगा. Dependency is a new normalcy for the patient now, so he later on decided for hospital-based palliative care. And the most important thing, we developed a support system even at Dehradun for the patient and the family. और सबसे important चीज ये थी कि उनको ये डर था कि during the travel उनको कुछ हो जाए. So that emergency was changed to a semi-emergency by way of good communication. In secondary palliative care, what we do, we deal with the refractory symptoms, like in this case was bleeding and bowel obstruction. We deal with the psychosocial and the spiritual distress, especially for this patient. Going to Dehradun was very important. Conflict resolution is very important because everybody feels that palliative care is just end of life care. Complex decision making, denial usually occurs very often in these patients and family members, and transition to hospice is definitely बहुत troublesome होता है, and you need patience and therapeutic listening. We admitted the patient. मैं यहाँ से थोड़ा rush करूँगा. So patient was having hyponatremia, stool occult blood was positive, hemoglobin was low. So to counteract the fatigue, we transfused 2 units and patient was discharged. Later on, as I already told in the anticipated event, so it was not new for the family. Patient developed subacute intestinal obstruction and later on landed up into complete bowel obstruction. Inability to pass motion and flatters, severe bowel obstruction and pain was there, weakness with vomiting. So we usually have an aggressive approach in this in palliative care at our center. We went for the Riles tube. We went for the antibiotics. Octreotide was given. Steroids were given to counteract the inflammation. And electrolyte correction was done very aggressively in a time-directed trial for 72 hours. On the 4th day, gastrographin study was done after hearing good amount of the bowel sounds, and flatus was passed, and the Riles tube drainage was less than 50 ml per day. At that moment, injection perinom was also started in a lower dose to increase the motility of the bowel. And on the 5th day, Riles tube was clamped. A trial feed of water was given and Riles tube was removed and patient was discharged on liquids and semi-liquids. On the OPD follow-up, patient was feeling better and passing flatters. Patient was on liquids. And as you can see in the picture, this was the follow-up after 5 days of admission for bowel obstruction with us. This is a very common quote said by our former president, Pratibha Patilji, and she said, "It is important that decorum and dignity of the house is upheld at all times. The image of parliament in the public mind should be one where proceedings, debates, and discussions take place in a very constructive and cooperative manner. Similar thing happens, and dignity should be upheld for patient even during the end of life care." So there is a very thin line between sympathy and empathy. Sympathy means सहानुभूति and empathy means समानुभूति. तो आपको उस तरीके से रखना है पेशेंट के साथ में अपना बिहेवियर जैसा आप अपने लिए चाहते हैं. So that environment you have to create. And I strongly feel that these 3 things are important. Patient's dignity, the caregiver's dignity, and doctor's dignity is also important during the discussions. Then only you can give good quality palliative care to the patients. So he was sent to Dehradun. He had love for the saplings and flowers. वो उनके पास पहुंचे. We provided a support system. So we talked to a local practitioner at Dehradun in case of any emergency. One teleconsultation was done because patient did not pass stool for 3 days. So enema was given. A medicine kit was made ready in case of any emergencies. And communication was a key for preparation. And this was the photograph which was clicked after follow-up in the OPD, and he was sent home at Dehradun. Lastly, because it was anticipated the disease will progress and patient will have a low hemoglobin and coagulopathy, so we went for an erector spiny plane block. We are fond of this procedure and we are also using this procedure in end-of-life care patients. So we introduce the local anesthetic and steroid mixture at L3 intervertebral, L3 transverse process. Later on, next new finding in few days was a bout of bleeding PR. Patient was having right shoulder pain, hemoglobin was low. So we thought it might be due to angina that shoulder pain was occurring, but TROP-T and TROP-I were negative. Because patient wants to buy some time for doing some pending work at Dehradun in the form of the financial transfer. So we went again for an aggressive approach and we transfused 4 units of blood transfusion to counteract that fatigue, and patient was discharged. Follow-up visits were made regarding the prognosis, and patient was again sent to Dehradun for signing the living will. So These things, this motto we follow at our center. We always treat the treatables, especially in an aggressive manner, for 72 hours before labeling the patient for futile treatment, and we palliate all the untreatables. This was the last admission, and it, as you can see, it was a very long admission of hospice care at our center as IPD basis. We gave just one blood transfusion very slowly over a period of around 10 to 12 hours to counteract the fatigue so that he can celebrate his 77th birthday in a hospice care setting. That was the wish of the family. Erector spiny plain block initially was given a single dose, and now we introduced the catheter because he decided that he will stay in the hospital. We prepared the family for good end of life care. Respite care was a part because we told the family कि आपको hospital में रहने की जरूरत नहीं है. You can go for having a cup of tea at a nearby cafe. Son-in-law who was at Germany, he came to meet him. His granddaughter, she was 1.5 years old. She came and we allowed her into the hospital environment. We gave a family environment to the patient, and birthday was also celebrated. One more thing, dignity discussion was a part of rounds because मैं उनसे बहुत छोटा था, तो उनके जो दिन की, जो उनकी life की जो experiences है, we usually talked about them, and every day this communication was done by our team. And the last moments, he was not shifted to ICU. Family was by the side of the patient, and end of life care was given in the ward. As you can see, she is a doctor from our team. She is giving top up of ropivacaine in the erector spiny plane catheter, and they are having very light movements. And this picture was taken just 5 days earlier to his death. This is how we introduced the erector spiny plane catheter at L3 transverse process. You can see the hydrodissection with saline and a beautiful catheter in place. Because he had love for saplings and flowers, so we made sure कि हम उनको wheelchair पे बिठा के जो हमारे hospital के बाहर में garden है उनको वहां पर ले जाएंगे. And as you can see, what is important is to develop a compassionate environment, starting from the guards to GDAs to nursing staff to doctors. Then only you can give a good quality palliative care to the patient as well as the family members. We usually follow this IMC strategy. We go for an integrated pain and palliative care management into an integrated comprehensive oncology services. We do good communications, and that communications are not only with the patient, they are with the family
unfortunately,
members.
we are out of time. We have exceeded our time.
Just 2 minutes. Communication with the family members, the patient, the attendants, the hierarchy, the doctors, nurses, as well as the management people. Then only what you can see in this picture, जय हो मूवी में कहा गया था कि एक बंदे के साथ अच्छा काम करो तो वो 3 लोगों के साथ और अच्छा काम करेगा. So इस तरीके से when you give knowledgeable content to the family members in the form of good quality palliative care and education, then these people also they create awareness in the society. This was the picture when the birthday was celebrated in the hospice care. I have put a smiley, although I have taken permission from the patients, but because it is streamlined on the YouTube, so I have put a smiley here. So what is the aim? English वाले सफर को हिंदी सफर के अंदर convert करना है. This is our team. अकेले आप सब कुछ नहीं कर सकते 24/7. So you should build a team to get to do all the things. This was lastly. This was a testimonial which was given. And they said that we gave best possible treatment, not only in the form of physical control of pain, but the psychological well-being also. And they said that he experienced meaningful time with his loved ones. Support system was provided beyond the medical treatment by open and honest communication, especially during the challenging times. And it was not only for their father, as written here, it was for the entire family. This emotional support was given. And this is the last slide, what says that we think that hospice means only death. This is not the case. The family also said this thing, as we watched you all take care of him, we realized that it really means celebrating life. Thank you.
Thank you, Dr. Sunny, for that wonderful talk. There's a lot that needs to be said, and you've somehow managed to cover it in your stipulated time. So Dr. Sunny has brought out the best of both worlds. So in a multi-specialty hospital, a multidisciplinary team approach, along with the empathetic approach. Now, our next speaker is Nankar sir, who we deeply respect for being the leader in pain management in Pune. And he will be talking about the third case scenario in which we are trying to apply the principles of palliative care in our own small way that we can. So to introduce sir, again, no introduction needed, but just for formality, he is the program director currently at for the chronic pain fellowship at D.Y. Patil Medical College and Hospital, Pune. He is the director of Meenakshi Pain Clinic, Nigdi, and Arjuna Pain Clinic at Baner, Pune, and he is the founder president of Society for Study of Pain, Pune. He has 5 publications and he has authored book chapters in textbooks. There's 21 chapters. So over to you, sir.
Good. Thank you, Nivedita, for these kind words. To start with, let me give my sincere thanks to SSPP Pune for organizing this very important seminar on cancer pain management. And care whichever is possible when you are working in an institute with a good team with support to you. Here, I will be presenting you a case of similar and how I applied all these principles which we are listening for last few minutes in our private practice. Friends, how common is this cancer pain as a problem? The epidemiology of cancer pain among diagnosed patients of cancer, as the different data suggests, here is a record of a systematic review of 52 articles, and which says that the patient who are receiving anti-cancer treatment, almost 59 to 60% of patients suffer from pain. The patient who has got advanced stage or metastasis, 64% of patients have severe pain, and the patients who are cancer survivors, that means they are positively came out of that cancer, even 33% of people who are suffering from, who are survivor of cancer may suffer from severe pain. So this is the significant data of patients who are suffering from cancer pain. What is the solution for this? Why so many people are suffering from this cancer pain? They have complex pain syndrome that are not managed by other physicians. Please note that many times these patients are coming to us, and previous to us, they are managed by different people and suffering in spite of they are on analgesics or they are on different pain treatments. So there is an increased need for resources to treat these patients at different centers with a multidisciplinary team. As previous speakers, they have explained how the multidisciplinary team is useful for this thing. I will not explain this in. So the ultimate goal of managing this patient is, most important is pain relief. The second thing is functional recovery to improve their quality of life. This we have listened. In addition to that, there is evidence in the oncology literature that survival rate are proportionately related to symptom control, and that pain management contribute to better survival and better psychosocial functioning and quality of life of this patient. So pain management is very, very important Even that can help to increase the longevity of the patient's life, improve their quality of life. So this is the ultimate goal when we are handling this patient, when we are managing this patient. The fact about this pain management is systemic analysis, as they are this patient, they control pain in most of the patient, but 15 to 20% of patients' pain is controlled inadequately, even with escalating doses of these analgesics. And this is the problem where we as an interventional pain physician can help this patient. So what are the different modalities at our hand? Neuroaxial anesthesia, sympathetic block, peripheral nerve block, radiofrequency ablation, cryoablation, and so many other interventions are there at our hand. And we have to choose appropriately at the appropriate stage for the specific patient. Here, I'm going to present you an important case. This is a case report. This patient was suffering from all this for 3 years, and she was presented to me in this July 2022. 59-year female, having pain in the right shoulder, chest, right upper limb. The pain was constant, sharp, and very severe, excruciating pain. It was radiating to the medial aspect of the upper arm, elbow, and anterior chest wall over the right pectoral region. In addition to pain, she had tingling sensation in the posterior shoulder region, supraspinatus region, upper arm. She had nausea. She had sleepless nights for so many days. She was unable to perform activity of daily living since last 3 months, like taking bath or putting the clothes. She was constantly crying. I saw her in the ambulance, as it was not possible for her to walk in my consulting room. When going to the past history, she was diagnosed a case of high-grade myxofibrosarcoma of the right thigh in 2012. At that time, she received brachytherapy to cure that cancer. And in addition to that, she had a surgery, that is mastectomy on the right side in view of distant metastasis. This was in 2012. In 2014, she developed an inguinal node on right side that was biopsied, which proved to be metastatic. And for that, she received radiotherapy and chemotherapy. She was all right for 3-4 years. In 2018, she again had a recurrence. At that time, she received a bone amputation of the right lower limb, radiotherapy and chemotherapy after this surgical intervention. In 2019, again there was a recurrence in the stump, which was receiving radiotherapy and chemotherapy. And in 2022, when she was presented to the pain clinic, she complains of this pain in shoulder, chest, upper limb. At that time, a whole PET CT scan was done, which showed a nodular lesion in the right upper hemithorax. There was erosion and lysis of the D1 and D2 vertebral bodies. There was an erosion and lysis of the right first and second rib. And there was some intraspinal extension at these levels. This is the PET scan report or the image of that, which shows there is a plurogenously enhancing pleural base mass seen in the right apical hemithorax. The lesion appears to erode right half of T1 and D2 vertebral body with a intraspinal extension. Initially, on that day, she received tablet paracetamol 1000 mg, pregabalin 75 mg, tramadol 50 mg, as she was already receiving some minimum dose, antiemetic, antacid, and she was advised hospitalization on the same day. When she was hospitalized, she received a CT-guided placement of thoracic epidural cannula. With the help of 18 gauge 2-way epidural needle, it was introduced at the level of T4-5 as she had a lesion at T2, T3, and there were two clear anatomical location seen. The epidural catheter threaded the tip at the level of T2 T3, which was confirmed by contrast by injecting 2 ml of iodine contrast. The catheter was then subcutaneously tunneled and fixed for the subsequent injection. And initially, the patient received 3 ml of 0.25% bupivacaine, 40 mg of triamcinolone, and 2 mg of dexamethasone through that catheter. Here is the image of how the CT guidance helps us to put the needle at the T5 level. Here you can see in this image the contrast is placed, which is confirming the needle or the drug is going into the epidural space. Then after putting the cannula and the contrast, we confirm that the contrast is reaching up to almost T2 level, and that confirms that the spread is adequate. And on the same day, within 15 minutes, her pain score reduced from 10 to 2 within 15 minutes. And in the evening, her pain was reduced practically to 1. Next day, when she was assessed in the ward, her score was 1. She had a good night's sleep because of the good relief in the pain. She was taken to the operation theater with a C-arm, monitoring vitals, and confirming the tip of the catheter in the appropriate epidural space with contrast. And then we injected 2 ml of 6% aqueous phenol very slowly, and she was observed for half an hour. Next day, again, she had a very good night's sleep. Her score was 1 only, pain score. And again, she was taken to OT with fluoroscopic monitoring vitals and second dose of 2 ml of 6% aqueous phenol injected slowly. On that day, we removed the catheter and she was observed for half an hour in the operation theater, and then she was shifted to the ward. Next day, her WAS score was 1. Paresthesia earlier, which was there 100%, which was reduced to 50%. Pain was significantly reduced. We stopped her tramadol required. And then she was discharged with a prescription of paracetamol 1000 mg TDS and pregabalin 165 mg for her paresthesia. 15 days after the discharge and subsequently after 1 month, she was seen in the clinic. Fortunately, her visual analog score was 1 to 2. She was ambulatory with a wheelchair in house. Just now we saw how the patients are happy when they are moving in the wheelchair if they are totally non-ambulatory in the house. So this was a very good moment for me also and for the patient also, as she was wheeled in my clinic without pain. We continued her neuropathic medicine and paracetamol as required. Days passed. For 3 months, that is second, third and fourth month follow-up, her usually the VAS remained in range of 3 to 5. She was ambulatory in the house with a wheelchair. Please note that the patient had an amputation of right lower limb. That's why she was in need of wheelchair. We continued her neuropathic medicine, paracetamol 1000 mg 3 times. And during this period, she was maintained with a minimal dose of morphine, maybe around 20 mg in 24 hours to control her pain. 5 months. Follow-up at the 5 month, her morphine requirement increased up to 60 mg in 24 hours. So we started a sustained release morphine tablet 30 mg twice daily. At that time, she also developed some mouth ulcer, which was treated with local ointment with IT. But she started getting drowsy in a week. So we have to reduce the doses of morphine from 60 to 20 mg gradually. 1 month passed. She was not in a position to come to the clinic. So we went to patient's home. She was bedridden. She had edema. She was not able to swallow. She developed bed sores as she was pointing the pain towards that. Unfortunately, she was seen by a local physician day earlier and he started some duvelar patch for us and he stopped morphine. So we again started morphine with a very low dose and we suggested a sublingual buprenorphine or sublingual eugesic tablet in case she gets a severe bouts of pain in between. On the same night, we receive a call that patient is died, but she died peacefully. There was no pain, and relative came to me for that death certificate. This was the message I received from the patient's relative. Dear doctor, we knew our mom wasn't going to get better, but you made her remaining time as comfortable and happy as it could be. That was all we ever wanted, and we will always be grateful. Thank you for such devotion to your patients. You are a wonderful doctor. Friends, the conclusion of all these things, neurolytic blocks are a very important in armamentarium of our pain treatment. These techniques are more feasible, cheaper, and equally safe and effective if they are planned correctly. Here in this patient, I put a catheter, epidural cannula. The advantage is that it was done under CT, so there was a safety involved. Daily verification of pain relief and catheter position was possible. We could give a daily dose for 2 days, total volume of phenol never exceeding 2 ml. And most importantly, the patient was in absolute comfort when we are doing this procedure. The possible risk involved hematoma, infection, dural puncture, as in most of the invasive process was explained to the patient very well. So, ultimate goal from our side is optimal pain relief, improve the functionality of the patient, and to give the patient a chance to enhance their quality of life. The challenges which we face in our small clinic or in this thing is the symptom of cancer often change over time, and there is a need for re-evaluation of the underlying disease process every time. New symptoms can manifest from treatment or from progressive cancer, either locally or distant site. The diagnostic workup of these possibilities is important in determining the treatment plan. And sometimes there is interference in our treatment plan. It may be by a patient's relative, it may be by some treating doctor in between. So we have to constantly discuss this plan with patient's relative, and try to give the best possible. The pain physician has got a very important role to improve the quality of pain control for this patient. Why? Because they implement a multimodal therapy. They use topical analgesic, judicious use of opioids, anticonvulsant, tricyclic antidepressant, and so on. And most important is titration of doses associated with the therapeutic effect. That is the key principle when we pain physician are working with this patient. To conclude, each patient's case provides an opportunity for reflection and reminds pain practitioners to learn, advance, develop algorithms to best treat each patient. These are my references. Thank you. Thank you for attention.
Thank you very much, sir. So that was again a wonderful talk which described to us that wherever we are, in whatever way possible, with all the knowledge, expertise that we have, we can always provide relief to patients. And when I spoke to sir about today's seminar, this was exactly what he visualized that we should put across through this webinar, which I feel we have done successfully. Now, to end the talk, we will now take questions. We are open for discussion. I will first start with one question which has already come in our chat box. The question is for Nankar sir. So the question is, why have we given the second dose of epidural phenol on the next day?
See, basically, there are no guidelines for this thing, but what we have observed or what we have seen in the literature, that usually these doses are repeated because initially we give a very small dose, try to see the result, and subsequently by giving a top-up dose again, try to increase the duration and try to give a good relief to the patient. That's what the idea. But there are no standard guidelines for this thing. Even people have given epidural alcohol for different type of pain. But even in those cases, they have given 2 days, 3 days, depending on the patient response. So that was the idea of giving it for the second dose. Thank you.
Okay.
Excellent presentation by all the three speakers today. And each one brought a very different aspect, starting from Priyadarshini, where she talked about total pain and the psychosocial aspect, which is very, very important as those of us who have dealt with terminal cancer care patients. And here I would like to point out one thing, that pain physicians should be involved right from the beginning. People should not wait till any end of life situation has arisen or advanced stage in the cancer has arisen, because like Nankar sir has just said, like say in the case of chronic cancer of pancreas, giving a celiac plexus block really helps the patient to retain all his daily activities, keeps the dosages of other medicines much lower. So pain physicians should be involved as a team, whether he's practicing palliative care or working as a pain physician, but affiliated with all the palliative care centers. And Nankar sir, yes, you are very right. And I think we have forgotten the art of giving intrathecal or spinal neurolytic blocks, which are very, very important. And it's very well appreciated that you are doing sometimes these potentially quite dangerous procedures with an ease. And that's a very important technique for all of us to learn from. And Dr. Sunny, I must compliment you on managing a case which I hope no student gets in any examination. I mean, the Viva could go any which way. I mean, a fellow had so many comorbidities and you managed them excellently.
Thank you.
Great job, all three of you.
There is a question in the chat box that in which position the patient has received phenol. Should I talk on that?
Yes, sir, please do.
See, why I choose phenol in this patient? If we are using alcohol, my fear was that it is a hypobaric, and so the spread of alcohol cannot be easily controlled. So I chosen phenol for this patient, and we can control the spread. And the patient, when I am injecting phenol, this was injected on the next day. The patient was in an operation theater. Patient was in a supine position only, and patient was very comfortable. So there is no, because the catheter was there, just many times the catheter tip may migrate up or down or somewhere. And that's why we have confirmed by putting a radiopaque contrast under fluoroscopy, confirming that it is in the epidural space only. And then we have injected phenol very slowly. So we can give any position if we are giving phenol in the epidural space. For as far as alcohol is concerned, probably we have to change the proper position. And it is difficult also in case the patient is having severe pain to give a proper position for that. So that's why we prefer to do it under CT guidance and with all this cannula in place. And thank you.
Yes, thank you, sir. Any more questions? You can either type in the chat box or please raise your hand. Okay, so
Yeah.
if there are no more questions, I would like to hand
question.
over to Vaishali, ma'am.
Yeah, there are no questions in on YouTube channel or Facebook also. I think that all the three speakers were so much explanatory and in details that there are no queries or questions. Madam Kulkarni Madam, Dr. Sunny and Nankar sir had a wonderful presentation. And since we all know that cancer pain or the cancer or malignancy per se itself has so much of a dynamicity that it keeps on changing every other day. and to be on toes or to evaluate again and again. That's the most important thing that we should be doing when we are dealing with the malignant pain, pain of malignancy. And yes, I really appreciate each of the speaker with the depth and the passion. The most important thing is the passion that I could see while dealing the patients, and that is really wonderful, and lot of things to be taken at home. I mean, messages to be carried with us. So thank you Nankar sir, Dr. Sunny, and Kulkarni madam. And yeah, with this, we will end the session. And with this, I really want to invite each of the viewer to our ISSP Con Pune 2024. And we have chalked out the scientific program, keeping in mind the wide interest of all the delegates. So would like all of you to see in the ISSP Con 2024, we have workshops. We are planning to have live workshops also. And the scientific program is mixed bag of everything that one can see forward to. Yeah, that's all. Thank you once again, and see you at ISSP Con 2024. Good night.
Good night. Thank you very much.
Everyone. Good night.
Thank you. Thanks.
Thank you. Thank you, everybody, for patient listening and encouraging us. Thank you.
Thank you.